So good morning. Welcome to today's lecture, which will be held by Carlotta Barbon, as a first-year resident at our institution, and she will be talking about esophageal cancer. Enjoy.
Thank you. Good morning, everyone, and thank you, Dr. Fetter, for the introduction. So today I'm going to talk about esophageal cancer. So these are the topics I'm going to talk about today: incidence, epidemiology, the types of esophageal cancer and their risk factors, the clinical manifestations, diagnosis, treatment, and then prognosis. So this is a map of the world of 2018. And as you can see, esophageal cancer is not distributed in the same time in the world. There is a higher incidence of esophageal cancer in South Africa and also in the Eastern world. And especially the area that goes from Iran to China, it's called the esophageal cancer belt, and this is because it has a very high incidence. The disease is the sixth most common cause of cancer death worldwide, but if we consider the third world countries, then it is at the fifth place. And this is because of the increased incidence that it has there. As you can see from this graph, the incidence is not the same in females and males. There is a higher incidence in males, and the incidence is higher by 3 to 4 times. This graph shows the death by esophageal cancer, and as you can see, in males it is the 7th cause of death by cancer, but in females it is not among the first causes. So which types of esophageal cancers are there? Question to my colleagues.
There's the adenocarcinoma and the squamous cell carcinoma.
So these are the two main cancers. And can someone also please tell me the risk factors for these two cancers?
Reflux for adenocarcinoma and smoking for squamous cell carcinoma.
Okay, thanks. So these are the main risk factors. For squamous cell carcinoma, there is smoking, alcohol, hot beverages, and papillomavirus. Whereas for adenocarcinoma, smoking, it has a lower incidence. And then there is gastroesophageal reflux disease, which predisposes to Barrett, and then obesity. And this is because obesity predisposes to esophageal reflux disease. What is interesting is that the two types of cancer have different incidence in the world. So we see adenocarcinoma much more in the Western world, whereas squamous cell carcinoma is much more seen in East Europe and Asia. And we, in Europe, we actually saw a change in trends in the 70s. So we also had more squamous cell carcinoma before the 70s, but then squamous cell carcinoma has been decreasing and adenocarcinoma has been increasing. And the reasons probably stem from the risk factors, because in our Western world, there has been a decrease in smoking and alcohol, but an increase in obesity. So where does esophageal cancer, where is it found? The squamous cell carcinoma is found mostly in the upper esophagus and in the middle esophagus, whereas adenocarcinoma is mostly found in the lower esophagus and in the gastroesophageal junction. And this makes sense because that is where we find the reflux. So this is the Sievert classification, which is important because it specifically addresses cancer at the gastroesophageal junction. It is divided in 3 types. Type 1 is for cancers that are above the Z-line from 1 centimeters to 5 centimeters. Type 2 from 1 centimeters to 2 centimeters below the Z-line, whereas type 3 from 2 centimeters to 5 centimeters below the Z-line. And why is this classification important? Because it guides us in the treatment. Because type 1 cancers tend to have lymph nodes in the mediastinum, and therefore usually we treat them like esophageal cancer. So we perform an esophagectomy, an upper gastrectomy. Whereas type 3 are treated like gastric cancers, and therefore we have to perform a total gastrectomy. However, there is debate on how we should treat type 2. So should we treat them like esophageal cancers, or should we treat them like stomach cancers? Can please someone from my colleagues tell me which are the main clinical manifestations of esophageal cancer?
So dysphagia, first to solids and then to liquids, or weight loss could be another one.
Excellent. Exactly. So cancer, esophageal cancer is a space-occupying lesion, and this is why we first see dysphagia, and in 20% of the patients we also see a decrease, pain while swallowing. In half of the patients there is weight loss, and this is for two main reasons. The first one is because patients have to change their dietary habits, and also because of the cachexia caused by cancer. Another manifestation could be hoarseness and cough. However, this is a bad prognostic sign because it means that the recurrent laryngeal nerve is involved. So now we spoke about how this cancer can present, but how can we diagnose the cancer? So the most important thing is that we need a biopsy. We need histology, and so the first thing we perform an upper endoscopy, and we perform the biopsies. And then once we have a diagnosis, we need to see the depth of and the spread of cancer. So we have to perform the locoregional staging, and this is done thanks to the endoscopic ultrasound, which has a very high sensitivity. And this is the TNN classification from the American Joint Committee on Cancer and the Union for International Cancer Control. So if cancer is just limited and it does not breach the basement membrane, it is a T1A. If it stays in the submucosa, it is a T1B. If it reaches the muscular layer, then it's a T2. If it crosses the entire esophagus, then it is a T3, and this is easy to occur because the esophagus does not have a serosa. Whereas if it reaches other organs, then it can be T4A or T4B. If it is for A, it is still potentially resectable, and this is because it invades structures like the pleura, pericardium, azygous vein, diaphragm, or peritoneum, which can be resected. Whereas if it is a T4B, unfortunately, we cannot resect it because the structures involved are aorta, vertebral bodies, or trachea. And what about the distant disease? We have to perform, the guidelines say that we can perform a CT. However, PET-CT has a higher sensitivity, and this is why in Switzerland we usually perform directly the PET-CT, because often patients undergo CT, which is negative, and they still need to get a PET-CT. So as you can see, this study shows how the CT has a lower sensitivity and specificity with respect to PET. However, PET still has difficulties in detecting lesions that are smaller than 1 centimeter. And then what is also important in addition is the cancer is above the carina, then we should perform a bronchoscopy to see if the airways are involved. And if it is a squamous cell carcinoma, we should perform a laryngoscopy to see if there are synchronous lesions in the head and neck. What is also interesting is the common metastatic sites, which are different according to adenocarcinoma or squamous cell carcinoma. Adenocarcinoma tends to metastasize mostly in the abdomen, so in the liver, in the peritoneum, and in adrenal glands, whereas squamous cell carcinoma tends to metastasize in the lungs. And, but what is also, unfortunately, that we have to consider is that 50 to 80% of the patients present with incurable, locally advanced, unresectable, or metastatic disease. So now we have a diagnosis, but how do we treat this cancer? What do we do? So the first thing is to see if cancer is a T4B, if it has metastasis or extra-regional lymph nodes. If the answer to this question is yes, then unfortunately we just need to undergo palliative treatment. There is definitive chemoradiotherapy. Whereas if the answer is no, we have to see the distance of cancer from the upper esophageal sphincter. If the distance is less than 5 centimeters, then we should undergo definitive chemoradiotherapy. Whereas if it is more distant, then we can perform surgery. Surgery, but not only. We can, also what is important for esophageal cancer is neoadjuvant chemoradiotherapy. And why is this so? This is a study that has been performed in 2012, and it is the CROSS trial, so it is a randomized control trial, which was designed to show what is the role of preoperative chemoradiotherapy. There were two main groups. One group had 178 patients in which neoadjuvant chemoradiotherapy with carboplatin and paclitaxel was given for 5 weeks together with radiotherapy, and the other group was comprising only 188%, and the patient only underwent surgery. So the study has been able to show the resection rate, the pathological response rate of the two groups, the overall survival, and also the postoperative complications. This graph is pretty clear, and it shows very nicely how patients that undergo preoperative treatment and surgery at 5 years have a higher overall survival, because 47% of them were still alive, when compared to patients that only undergo surgery, in which the 5-year survival was 34%. What is also interesting is that the R0 resection was much higher in the pretreated group, and it was 92% against 69% in the group that have only undergone surgery. This graph also shows that not only there is an improved response from patients that undergo the neoadjuvant therapy, but that also squamous cell carcinoma and adenocarcinoma behave differently. So the two lines above show patients that are that received neoadjuvant therapy. So as you can see, the survival is increased. But once, with the sub-analysis, they saw that squamous cell carcinoma actually has an even higher response rate with respect to adenocarcinoma. Indeed, the pathological response overall was 29%, but it was 49% in patients with squamous cell carcinoma, whereas it was 23% in patients with adenocarcinoma. So what is important now is this cancer has different invasion, and so according to the type of cancer we have, there are different treatments that we have to consider. So if the cancer is a T1A or T1B, we can consider just surgery, but we can also undergo endoscopic resection. If the cancer is a T2 but has no lymph nodal involvement, then we can perform just surgery or go for neoadjuvant radiochemotherapy. If it is a T3 or T4A, or if the lymph nodes are positive, then we should perform the neoadjuvant chemoradiotherapy according to the cross trial. Whereas, as said before, unfortunately, if it is a T4B or if metastasis is positive, then we have to undergo palliative treatment. So which type of surgery can we perform to address this cancer? There are mainly 3 types of operation we can perform. There is a transthoracic one, a transhiatal, or tri-incisional. The anastomosis can be performed, can be thoracic or cervical. The conduit to reconstruct the esophagus that we remove could be the stomach, which is the most commonly used, colon, or very rarely jejunum. And the techniques that we can use are open, hybrid, or totally minimally invasive. The most important technique, the one that is mostly used, is the Iver-Lewis, which is a transthoracic technique, which the anastomosis is thoracic, and which the reconstruction is performed through stomach. So how do we perform this technique? It has 2 main steps. The first step is abdominal. We have to perform lymph node dissection and create the stomach conduit, which then we turn the patient and we perform a thoracoscopy, and we isolate the esophagus, and then we have to pull up the gastric conduit that we have previously created, and then perform an anastomosis between the remaining part of the esophagus and the gastric conduit. But how is minimally invasive surgery compared to open surgery? So there is a study that was published in 2012 on Lancet that actually addresses this question. It was a randomized control trial with 2 groups. 56 patients were treated with open surgery and 59 patients were treated with minimally invasive surgery. And the endpoint of the study was to show the postoperative morbidity. What is interesting is that the study shows that pulmonary infections are less in the patients that were treated minimally invasively, But what is also very interesting is that there was no difference in the secondary outcomes. That is, hospital stay, resection margins, and the mortality were the same in the two groups. So this study shows that we can perform safely the minimally invasive surgery. So arriving to the prognosis of this cancer, once again, squamous cell carcinoma and adenocarcinoma are different. They behave differently because squamous cell carcinoma tends to occur more local regionally, whereas adenocarcinoma tends to have more distant metastasis. This is an image that I got from the Surveillance Research Program of the NIH, which shows that the 5-year survival is 19.2%. However, survival is different according to the cancer stage. So if the cancer is localized, the relative survival at 5 years is 45%. If the regional lymph nodes are involved, then the survival is 23.6%, where if we have metastasis, survival is very low, unfortunately, it is 4.8%. So what are the take-home messages from today? What is important is to keep in mind that we have two different types of esophageal cancer, the squamous cell carcinoma and the adenocarcinoma, but we are going to see mostly the adenocarcinoma. If there are metastases, we cannot perform surgery, so we have to undergo palliative treatment. If the cancer has a low stage and it is T1 or the lymph nodes are not involved, then we can consider the endoscopic resection. If there is the stage is more than T2, or if the lymph nodes are positive, then according to the cross trial, we should perform both the neoadjuvant chemoradiation and surgery. And the standard surgery that is mostly performed is the minimally invasive Ivor-Lewis esophagectomy with the gastric pull-up. And thank you for your attention.
Thank you very much. Very nice overview, very well done, very concise. One of the very important factors that you could not touch here, which is a very hot topic, is center and surgeon volume. Right? There is in esophagectomy and pancreas surgery and many other procedures an extremely strong correlation between experience of the centers, of the surgeon, and outcome by a factor 5 or even more. I mean, in this country, in Switzerland, I think we have more than 35 or 36 centers performing esophagectomy, while we need 2 or 3. So this is a huge difference between the need and what we have, and that affects outcome and that affects patient. This is the same, as far as I know, in the United States, is the same problem they have in that. My question is about the benchmark study. I think we did recently here with many other centers a benchmark study in low-risk cases. Could you tell us the main finding of this benchmark study?
Well, the benchmark study aimed to show where we're at with, especially with in respect to complications, to know from what can be expected from these surgeries and what is sort of where's the benchmark. So this was a study in over 800 cases and from multiple centers, and the complications were mainly looked at. And so in benchmark cases, basically said in patients that are not overly ill, and you can see then what complications are regarded as benchmark, and if you're above this, then you're good. If you have less complications, if you're below that, then maybe you should consider changing either your technique or going to people who have better or less morbidity.
Well, we're out of the topic. I think indeed probably we should define how many centers we need for these procedures, and that let societies or whatever decide which centers, and then monitor the outcome closely. I think this is the best simple solution. The Netherlands has done that relatively well. We see that's also the country where they can do so. It's not only better surgery and benefit for patients, but you learn something because there is experience. You can do a randomized trial, which obviously is an example here at the level 1, as Carlotta has shown, that in some patients, if you don't do now the chemoradiation before, it's clearly mismanagement. So this is a very strong study that was feasible. So I think this is one of the highest priority of the health system, to be able to centralize esophagectomy in a few centers for the benefit of the patients, benefit of politicians, insurance, whatever. It's really irrelevant in that. That should be for patients, and number two, progress in the disease. We've seen the outcome is pretty poor. Most patients are not alive at 5 years. Best case scenario, 20 or 30%.
That was overall, though. Those are also the patients that we don't see. I mean, I think important is also to see that the ones that we see and that we do resect are having actually, with the cross trial, especially with the neoadjuvant treatment, had quite a good outcome. So, yeah.
Okay, other question?
You have HPV as a risk factor. I heard there's a vaccination in Germany now for this. Do you think that's a good thing, and do you think it's coming in Switzerland as well? Because I heard you can go there and buy it and inject it yourself if you really believe in that.
I haven't actually thought of that. I mean, I guess because the squamous cell carcinoma, it is a risk factor, but the main one is smoking, so that's why probably this is not the hot topic for the esophageal cancer. But of course, if you can do a vaccination for something that is a risk factor, you should go for it. Yeah.
Concerning the neoadjuvant treatment, what is the goal of it? Is it to gain more resectability or to have a systemic tumor control? And if systemic tumor control, why don't we have an adjuvant treatment after surgery?
You can see that the R0 resection rate is higher. So yeah, you can probably get a better local, tumor control there, and you have a total, and you do have a realistic, quite a high total response rate, right? So that's very high. I think it is the local. I think it is both, and it's a good question. Why not adjuvant? Actually, it's not really answered if you need an adjuvant treatment or not. Because this is a very well-performed study, and it works very well. That's why the gold standard. But if an additional adjuvant treatment helps, is not really looked at yet. Currently, it's just done for we do adjuvant treatment just if there's an R1 resection. Now, that's clearly isn't the plan, but if that happens at a certain point, then there's a role for adjuvant treatment. Otherwise, there's not at the moment. But that's not based on good trials. That's the current practice.
I feel like I have to answer the HPV question. And actually, there is a vaccine out there. There's several ones. There's a quadrivalent vaccine out there. The recommendations now are to immunize teenage girls, and likely in the future, we will immunize teenage boys as well. My question would be, considering the most commonly performed esophagectomy, the Ivor-Lewis operation, what's the learning curve? How much do you need to have done until you become proficient?
Probably depends also on how you start. If you start open or totally minimal invasive, and it very much depends on how much minimal invasive surgery you did before. I think the learning curve, the technique itself can be difficult to say. The technique itself is you can learn it as a good laparoscopic surgeon. You can probably learn it relatively easily, but there are so many pitfalls and difficulties that you can run into, and I think that's the issue, that you need to anticipate all of these things, and that's just a lot of experience required.
I mean, we just have right now a special article that will appear this month in the Annals from the European Surgical about centralization, where esophageal surgery is one of the most obvious procedure that require centralization. The minimal number is difficult to define. I know come with the robotic and come with other challenges in terms of training these people, and there is certainly not a fixed number that you can impose. You have center numbers, which is one thing, and the curve is sigmoid, so you have a start when it changes better, and then you have the top when you reach a plateau. So there is a delta here of number of cases, whether it's 20 versus 60 or whether it's it varies in different conditions for the minimum number. But again, we have a challenge now to many go to robotic. How do you teach that? How you do that? And that's one of the reasons we have this benchmark study. So you can really somewhat follow this learning curve in the city. And some people never reach the learning curve. Okay, thank you.